Hi, everybody. My name is Mike Pitt. I am a pediatric hospitalist. I'm a professor at the University of Minnesota. I am Canadian, so Naomi and I have that in common. We worked together and we wrote a paper together on how to reframe unexpected news, bad news as unexpected news, specifically around the framework of sharing a diagnosis of Down syndrome. And so that's kind of our scholarship partnership. And I am a associate program director for the pediatric residency. I'm a fellowship director for pediatric hospital medicine, and then I'm a faculty development lead for the department. So I kind of run the gamut of who we educate, and excited to share some toolkit ideas to really expand the things that we're already doing well with some things you might not have thought about. So we'll talk about three things: mini chalk talks, specifically kind of how to be prepared with when you have a writing utensil only and a learner, and how to kind of flex the mini chalk talk. We'll talk a little bit about some game-based learning and how that differs from gamification, but how to apply some of those principles. And then per your 70% poll, we will talk about how to use vulnerability as a value in education. I will say I do have a financial disclosure. I'm a founder of a tech startup called Q Rounds, but I'm not mentioning it beyond this, so it's not relevant to what we're talking about. So again, when I say toolkit, we're going to talk about chalk talks, three things: game-based learning and vulnerability. This will be an opportunity to be interactive, so please unmute yourself or leverage the chat. Naomi, if you would mind keeping an eye on the chat for me if there's something I miss. Sure. And then if we have some time, we'll get a chance to get our hands dirty with some of these ideas too. So the first is from a paper we wrote on, again, bringing chalk talks to the bedside. And I'm just curious, and I'll look at videos or via the chat, how many people do bedside rounding as part in the hospital setting as part of their role with learners, kind of walking from space to space? Some, and then maybe some in clinic hands. Okay, so the frame I'm sharing the most here is kind of for this part is rounding, that traditional rounding, but this equally applies to if you were had a learner in clinic or sitting one-on-one. So first of all, when I say chalk talk, it doesn't require a chalkboard. That just rhymes and sounds nice. It's something where you are using a writing utensil, an educational moment you're seizing upon, and all you have is that writing utensil and a writing surface. What is fun is to start thinking about what can those writing surfaces be? Who has written on their scrubs before, or the window? A dry erase marker erases from a non-frosted window. Non-frosted is important. If it's frosted, it will smear all over the place. But a frosted window, a non-frosted window. So I use almost all of my teaching on rounds happens on the windows of patients' rooms or outside the room by carrying that dry erase marker and an eraser. And that mini chalk talk just means that I'm not saying gather round. I've been asked to give an hour lecture and I'm going to do it via a chalkboard instead of PowerPoint. I mean, I'm going to take this brief 1 to 3 minute structured moment using that writing surface, and we're going to use something visual to drive the point home. And I think unless we start to prepare for some of these things, you just walk from room to room and don't do it. So I'm going to spend a second on the why before we get into some specifics on the how. One is the framework just-in-time teaching. You know, that it is much more sticky. We are more likely to remember something if it is proximal to the encounter where it's relevant. So if I'm about to go have a difficult conversation and we do some prep just in time, I'm going to be better prepared. If I come out of a room and there was something that came up and we do some debriefing on it right now, it's going to stick in my long-term memory more. So one is by being prepared with this kind of cadence of chalk talks, we can put a visual bow on a just-in-time moment, capture bedside pearls, really leverage positive peer pressured learning, and we'll show some examples of this in the game section, where people are more likely to remember something if their peer knew it than if the teacher taught it at them. And again, it allows us to really do these what am I thinking, move away from those what am I thinking, or kind of pejoratively in the past called pimp questions, where you're just pointing to somebody and asking them to get inside your mind. This is a way to really share the space, teach to different learning styles. And I will tell you, by doing this, and people have kind of adapted this learning style, they'll start to, or teaching style, there's never a chance that people say, I was on service with them and we didn't do teaching, because you're always having this visual frame around a teaching moment. So we'll talk about this kind of using a bank account model, and think about the first thing you have to do is build your bank account. You've got to be prepared for a handful of talks that you could do visually, or teachable moments that you could do visually. And the way that we do this often is just, if we were in a workshop, is think through the teaching scripts or speeches you already have for common triggers when you're on service or rounding. What are those moments that you could pull into 1 to 3 minute visuals? Another way that we'll do this with people is have them go through PowerPoints they give and break those into 10 bank account items, 10 mini chalk talks that they could give, that they could stow away. And I used to physically have this in a Dropbox folder on my phone or in a notepad, and I would add to this, oh, I've got another chalk talk, I've got this. And now it's more just kind of in my own long-term memory, or a style of teaching I've committed to. But early on, it was really building that bank account, reflecting on your service weeks, taking out note cards or a notepad and jotting down the bullets of, here's a visual we could do, here's a teachable moment that could be really become that bank account that is auditable. The reason a card is helpful is it's the size of a window, the shape of a window. So if you're actually saying, what could I fit, not on something I keep erasing the board and teaching for an hour, but on one card, having that 3x5 card is a nice model, and allows you to jot on the back, what are the learning points? What do I want to make sure they get across? So I'll give an example. This is one, in the conversations about failure to thrive. This is a frequent trigger, or admitting somebody who's not gaining weight. When I draw upon that bank account, that first thing I might do is build this visual with the team. And I'll say, okay, let's think about failure to thrive as a bucket that needs to maintain a line to grow. So we need to fill that bucket. So I draw a bucket on the board. What are some problems that could lead to that bucket not getting filled? Somebody could say, they start saying, well, the faucet's not on. So I draw the faucet and we brainstorm some ideas that could be the faucet not being on. What else? I could be losing nutrition. So we talk about too much going out and draw a hole in the bucket and kind of give this visual. And then we talk about, well, maybe there's something about this patient's metabolism where their line needs to be higher. They're burning more calories. They're having seizures, et cetera, chronic inflammation. So this is not, let me do everything there is to know about failure to thrive. It's the first patient on the first day we're rounding, or the first patient, we're going to use this framework to orient ourselves visually. We'll round in the room. I might have the learners with the family use this to talk to the family about what our order set would be. What are we looking for? How are we going to measure these things with tests? And do kind of a do one, see one, teach one with the learners right there, where they're using this analogy with the families. And then the next time we go to the next patient that has failure to thrive, or the next day, we might really convert this into thinking back to our drawing. If you were to create an order set, what would go in the order set for failure to thrive? And we use that kind of blank space to fill that in. The key here, if you walk away with one thing from this section, it's that unless you audit your bank account and do what we call educational pre-rounding, which is where you take the time to say, I've got these 6 patients to see on rounds, or 10 patients. What will we talk about for each one of those patients? You will do what most of us do, which is go through and think, I wish I taught more today. You really if you take the time to look at your list on Epic or in the morning, and just say, oh, okay, we've got a failure to thrive. I'll do the bucket. We've got this. I'll do a differential diagnosis discussion. But you're committing to that educational pre-rounding, not just what is the management of this patient, but in your role, what am I going to do as an educator? And then I'm sure people are familiar with the phrase spaced learning, but taking that, what would be an hour talk, and breaking it into multiple 5-minute talks is going to be way stickier and have commit more to long-term memory. So when I see, oh, we've got an asthmatic patient on the team today, they're going to be here for 3 days. I'm thinking not, I should give my talk on asthma. I'm already thinking, okay, we've got 3 days to cover some things. What do we want to make sure we cover on the first day? And so really, as you're building your bank account, spreading things out that can be spaced out, and maybe have that natural progress of what would we want to do on day 1. So that might be, I want to have something visual for the diagnosis of asthma, something for the ER management, and I'll show you what I do for that. Maybe this is a case and I've got an x-ray I can draw. One of the most common drawings I do, if we've run out of things to talk about in asthma season or RSV season, and I'm like, we could easily just move on without doing any teaching, I start to pull into things that are adjacent topically. So still relevant, like we just saw a patient, we're talking about the lungs, but now I draw 3 lung x-rays, each with a foreign body in it, one with a circle that's in the trachea like this, one that's like this, and one that has a halo representing a button battery. And I'll write A, B, and C. And say, okay, which of these, all these kids were reaching in their mom's purse, grandmother's purse when she was babysitting, and they come in coughing and drooling. Which of these makes you the most worried? And then get people to kind of vote and play and get somebody to say, I think that rim means it's a battery. And I remember there's a problem with batteries. And so you get them to do the teaching. Even though that's not an asthma related topic, it's in my bank account for when we've run out of things to talk about for asthma. Outpatient management. So again, when I said the ER, what I often do on that first day is say, let's just remind ourselves what's the toolkit for treating asthma when you see it in the emergency department. What's the first thing you're going to give that kid comes in? So I write beta agonist or albuterol when they say it. And then I ask, okay, how does that work? And usually people know how that one works and they answer, say, okay, what might you try next? And we build out kind of an order of operations. And increasingly, you start, as you get down the list, people are like, I don't remember how Heliox works, or the senior resident knows, or the nurse knows, and the residents don't. But it's this cadence of, what do you want to try next? How does that work? Any pearls, like I might write down the pearls on the back of my card that I want to make sure I address when we hit this one. So, that we don't use anticholinergics on the floor because they haven't been shown to decrease length of stay, or that I thought everybody was doing it wrong when they were giving Decadron when I came to Minnesota for asthma instead of prednisone. But why is it that they do that now in the emergency department? So I might jot a few things to myself, but the bottom line is when I'm now on service and that first patient has asthma, I know the first thing I'm going to do is just when we leave that room, talk about the toolkit. Maybe the next time we're there or the next day, I'll talk about outpatient management and kind of do the drawing of different approach that we've all seen before, but equip residents to draw this on the paper sheet in the room, when to give to the family. I saw a resident trace the kid in clinic, draw their lungs, and then draw this picture, and they ripped off a life-size teaching handout, on that disposable paper. The other kind of strategy here, so those are a couple examples of asthma, but again, I might have 10 or 12, but that I would have normally done if the resident said, I'm going to give you a talk on asthma, and everybody sat resenting the fact that I pulled them out to talk for 45 minutes and give a PowerPoint presentation. I've now equipped myself with a week's worth of content to space out. One of the easiest ways to do this is to just start thinking about figures, that work well. And this is the figure in the paper, a meta figure of figures, that, if you've got things that have shared symptoms, I'm a big Venn diagram fan, you'll see one in a little bit, using the Venn diagram, but having people fill it in. And I sometimes will try to make these up on the spot where we're talking about a urinalysis and we'll say, okay, UA results, culture results, physical exam findings, kind of where's the gold standard, what might we think is a false positive, and kind of build that out together. 2x2 tables can be a helpful way for people to think through things. Simple anatomy, if we can draw an anatomy of a problem and think through the cases together. Analogies we talked about already, pathways, and then maybe there's just a well-known graph that I do something you'll hear later called vulnerability rounds, where we confess something that we don't understand and where we faked understanding for a long time. And this is one of those ones, like the shifting of the curve, all that stuff. I mean, I faked understanding for a long time. So sometimes using those to have the learner say, I struggle with this, help me understand how you wrap your mind around this, and they can teach up, can be a powerful tool. This again highlights that positive peer pressure. There's a value in when you've got this multi-generational layer of learners, of a med student and a nurse on multidisciplinary rounds. You can create a space where the nurse is sharing the teaching. One of my favorite ones is to say, if one of my kind of teaching scripts is, if we've had to put an NG tube in somebody, is we just come out the room and say, okay, what are some ways we could know that this NG tube is in place? Everybody has to give one idea. And you start with the nurse, and they might give something, and you kind of bounce around. But then you get to those that have worked in global health that know that if you don't have an X-ray and you have a cup of water, you can hold the tube upside down in the water and see if it's bubbling. And if it is, it's in the lungs. So you get to kind of gather from peers and allow them to share. I call this a real-time mini chalk talk, where you build something together. And again, if you think so much of, like, if you put a figure on a PowerPoint presentation that shows all the hemoglobin for iron deficiency versus chronic disease, the RDW and all these things. If you dump that all up on a screen, it's overwhelming. But if you build the box, even in your own PowerPoint presentation, and then you have people do the exercise of what goes where, and that table becomes 10 slides, building, it's a way to get people even more engaged in your PowerPoint. But obviously with a chalk talk, I'm just going to draw a blank table and we'll fill it in together. A couple ways I do this. I used to carry dice on rounds. I'd throw them and we come up with a number 9. Okay, we just came out of a room of a kid with sickle cell. What are 9 things we can teach each other about sickle cell? Let's go around the table. Or the rounding room, and everybody has to say one thing, and it's very psychologically safe for the med student to go first, because there's an infinite thing to talk about. But it gets a little more challenging if you maybe go up that to senior resident, attending fellow, etc. I use another one called Pick Your Poison, where if I come out of a NICU graduate's room, I might say, you're going to read the discharge summary, or you'll work in the NICU. It's loaded with acronyms, and I might just choose 6 and write them on the board. NEC, PPHN, TPN, GIR, ROP. And I've written those on the board, and then I say, okay, if you know what one of these is, tell us, and we'll cross it off. And so they say it, they teach something about it, we cross it off. But they're doing the teaching, I'm facilitating. But in my bag of tricks is I can put 5 things up on the board and let them cross them off as they teach them. And again, there's that psychological safety. A fun version of this where you build with really safe, because there's and then get a little more challenging. When I leave the room of a patient with a urinary tract infection, I say, okay, well, let's remind ourselves interpretation of a UA. What's on a UA? So they just start. And as they're saying things, I'm writing them on the window. And then, so that felt really safe. Everybody volunteered stuff. And now I say, okay, pick one of these, Tom, pick one of these, teach us something about it, and I'll cross it off the list. So again, they have this multiple choice way to think about what they want to teach, an infinite amount of things they could talk about from there, but it's the group doing the teaching, and it's really codifying that teaching moment using the mini chalk talk frame. And then the last example of this is just drawing a stick figure, and almost everything you could teach could be done with a stick figure. So let's talk about side effects of steroids. Draw a side effect on the stick figure that we might see. Side effect ways that cystic fibrosis might present. Like you can use a stick figure to kind of do a lot of teaching where people fill in things in that space. The point is, I've gotten to the point where I do not leave a room without doing something at the window, and it takes about a minute per patient, but I do not then teach in the afternoon, because nobody likes that. Nobody likes being pulled away from their notes and the stuff they're trying to do in clinic to sit for 45 minutes to feel they got taught. I forced this into rounds, and it's been a cadence that's really been very well received. And again, that's that making a withdrawal. Now I've built the bank, I've done my pre-rounding, and I'm thinking, where can I do this? The window. I set that expectation that first day of rounds. We're going to stop and do teaching at every room. It'll take no more than 2 minutes per room. I promise we'll be finished for lunch every day by noon. And but I won't find you at 1 o'clock and say we're going to do a topic. And you just watch this relief of people having that frame. And again, that's facilitating with people rather than teaching at. So I want to stop for a second. I'm curious, those of you that have been already doing this or have a handful of things that you already draw, are people willing to share some things in the palliative space? And I actually saw the last time I gave this talk, somebody talked about a Venn diagram they do to separate palliative, hospice, pain management, to really actually do teaching about their own role, in that sense. But curious if people would be willing to share some ideas they had about this. Frosted window. I see Amy had that. Who's willing? Anybody willing to share a drawing they do?
So this is Becky Oakley, and I'll share. I do home-based palliative care, so I don't have the opportunity to do it from room to room or anything like that, but we do have a closed Facebook parent group where they share lots with each other and that sort of stuff. And what a great idea you've given me to throw some terms out, let parents kind of say what they know, ask what they don't know. I'm really excited to see how this will go in that space, which is all private and great, but I think it's going to just be fantastic.
Yeah, that's great. Thanks for sharing that. And yes, certainly, this we have a resident who did this really well with family drawings that work well for families. She did a workshop on how to think about drawings that translate really well for a family to be able to redraw. Families love analogies when you're trying to explain a complex process, and when you can give them a visual to then be able to describe it to others. Yeah. Who else?
I was thinking of the mechanisms involved with nausea and vomiting, like being able to say what goes into the vomiting center and what neurotransmitters involved, and then use that to figure out what medication should be used in each
it's great
pathway.
Yeah, I do a stomach often. So whenever there's a kid with vomiting, I will draw a stomach and I write the letters HCl in it. And I say, this is going to get you a question right on your boards. Because every time you take the boards, there will be a question about a kid with pyloric stenosis and which type of alkalosis they have. And all you need to remember is what happens when what's vomit made up of? And they say HCl. So I write that. So if I'm vomiting that out, is my HCl going to be high or low in my blood? It's going to be low. What about my acid or base status? And then we draw a cell with an HK transporter. And if my H is really low in my blood, because you just told me I vomited it out, what is this K going to do to try to get more H out of the cell? It's going to suck it in. So I get to this hypokalemic, hypochloremic metabolic alkalosis without having to remember that phrase. So yeah, vomit is a fun thing to draw too. Just the arrow up at the stomach. Any other ideas there? Well, yeah, what I want to challenge you to do is just flip this switch and start saying, what's the drawing for that? What's the visual? It doesn't, what is the visual and that cadence that could be brought to my kind of cadence rhythm of rounds or working with patients? We'll pivot into another tool for your toolkit, and it's important to say toolkit. I will go months without using a game in medical education, but then I will use principles in talks all the for a long stretch. So this is not that every talk you do should be a game. It's that variety is a valuable part of our toolkit. So what does it look like? This is from a paper I wrote on 12 tips for maximizing game-based learning. I do want to take a second on the definition. Game-based learning means applying, bringing the actual rules of games, winners, losers, that game environment into a teaching encounter, versus another term you'll hear sometimes called gamification, which is taking motivational aspects from games like leaderboards, a badge when you get 10,000 steps for 30 days in a row on your Apple Watch. Those models are called gamification, where you're trying to motivate people to change their behavior based on principles that are used in games. Both we can talk about it if you're interested, but specifically this is game-based learning, how to bring principles from games into education. And it really, a lot of it maps to this nursing literature where we look at our emotional affect, and it tends to plot somewhere on this circle. I actually use a version of this with my therapist to learn how to say my own emotion words better. I have a color wheel on my phone, but the concept, this was from the 1980s in nursing literature. And we want our learners to be in this upper right quadrant, usually, where we are activated and pleasant. And games can do this. We can build competition in a psychologically safe way that will keep us in this upper right corner. One of the ways to do it with psychological safety is to eliminate this concept of a wrong answer when you do a game, or a single right answer. Most of us, when we hear games in medical education, think of Jeopardy. That has been done. It's the 90+% of the game people that say they use games in education describe using a Jeopardy type quiz game. where we are writing things to have a single right answer and you're buzzing in and you get right or wrong and you earn points. I'm going to show you some examples of games that, one, a way to write questions that allow for engagement in a game environment without a single right answer, and two, a game that uses no right answers that we've published and used. So when I say, if a typical Jeopardy type question, a newborn female with a webbed neck, lymphedema of the feet, and wide spaced nipples may have which disease? Boom, I buzz in, Turner syndrome. I know this one, right? That's the typical way those questions are written. If I don't know that, I'm going to hesitate to buzz in. I don't want to be wrong and told I was wrong. If I reword this, these are three of many of the findings that may be seen in a female with Turner syndrome. I now have multiple right answers to draw from, and I'm willing to engage as a learner, even if I got two and blanked out on the third. So it's a way to just take the way you write the question in even a trivia-based games. It's really going from a Jeopardy style to a Family Feud style. Top 5 questions on the board. And sometimes I will use this in a chalk talk. If we have a kid with meningitis, I'll draw top 5 bacterial culprits on the board. And I know the order of that, and I might have glanced at it right before that patient. And then people could guess, and if they say E. coli, oh no, we're going to put that down here at 4. Who's got the top answer? Play it like Family Feud. This was a game we published, and this was built out of necessity because I was giving a talk in Tanzania and the power went out, and I couldn't use my slides, so I created a game on paper where we generated on 3 stacks of paper. Stack A was a chief complaint, age and sex. Stack B was a chief complaint, and stack C is an abnormal finding. And so this was that original combination, age and sex, list of chief complaints, and something abnormal. But now you shuffle the cards and people generate a random case. So it's like a slot machine. They might generate a 7-year-old female with red urine and an abnormal chest x-ray. And so now we say, okay, well, go. What could this be? Well, the value of this from a psychological safety standpoint is I have not, there's no right answer. I don't have the answer. It was created in real time. So they're not trying to guess what I'm thinking. And they go, okay, how about acute chest syndrome? That's what's going on in the chest x-ray. And I believe you can get renal papillary necrosis and sickle cell. Okay, tell us more about that. So then the next person says, no, good pastures, the chest x-ray is pulmonary hemorrhage and the blood in the urine. And then the med student says, how about tuberculosis? And they're on rifampin and the urine's actually orange. It's not red. So it's this way to generate, and then you can add another, either stack B, now they have another symptom and you've got to narrow it down. You can add, now they have an abnormal genetic or newborn screen. And you've got to tease out which of the things could be on a newborn screen that could explain these symptoms. I've done it where you split the room in half and put a timer on the board. And it's the categories version of this. You generate a case and they have to come up with as many differentials in each team. But if they have anything that's the same, they cancel each other out. So then we go out and share differentials in that space. I've done it in the NICU where you add a gestational age. So you have 4 stacks of, you have a 6-day-old 24-weeker with X, Y, or Z. So it can be built. When we studied this, we compared it to traditional morning report, which was a single case being presented versus this game-based morning report. And people felt they learned more, enjoyed more, it was more participation, high attention, they liked it more. But when we asked who you learned the most from, in traditional morning report, it was the facilitator, and that just flipped to somebody else, a co-resident. I learned from my peer because they were sharing their ideas when we did game-based morning report. So just an example of that peer-pressured learning that can happen if you create an environment using games or chalk talks or any degree of facilitation. The other strategy here is to just borrow from what works. Don't reinvent the wheel of fortune. So think of games that you play with your kids and go, is there a way that we could make this a medical game? And not, the challenge is sometimes you do this and you go and you just make it a fun game, but you lose the objectives. I do a lot of research on jargon. So we've done a game on medical taboo that is like, I'm not allowed to say these words when I'm trying to get this point across, and people can draw those cards. I've seen a dermatologist make a matching game that was the game memory, and it was the word and then the visual. So you might have a bullous impetigo as a word and then later flip over something that was bullous impetigo, and you were playing memory with the team in that game. So curious if people have done games. We did an escape room workshop at PAS last year on how to use escape rooms for teaching. And it was an escape, the actual workshop was an escape room that people had to navigate to learn how to do escape rooms. But curious if anybody's used games or has ideas or thinking about things now, we can brainstorm together. I'm checking the chat here too.
I can mention what I put in the chat. I love that the slot machine or whatever those machines are called. And if you want to get like a surprise patient in role playing, and we'd have 3 different combinations, and then we get to practice specific communication skills depending on that surprise patient. That
I love it. You could have
you
could have a stack of emotions. You know, the patient is tearful, is angry. You know, absolutely. You could do a stack of emotions. You could do a stack of you could be non-English speak as first language. There's a lot of kind of nuance that you could put in to create a challenging communication scenario. Anybody other ideas on games or thoughts or things they've done in this space? And is that Tanya Aurora that I know? Tanya Aurora from California. Hi, how are you? I just unshared my screen. I'm looking at names.
You know each other? How do you
Yes, yeah. We do global health together. We've written a lot of papers together.
I was just chatting to you. I have used improv before as a warm-up in team meetings, but I've never used games. And I was thinking medical taboo could be that same thing when you have people who are nervous about going into a meeting and thinking about what to say. Just a quick round of medical taboo could get us out of our heads a little bit.
For sure. Yeah, and improv, so many, I mean, they actually are called improv games often. There's a great one called Rip Van Winkle. I don't know if anybody's done this one, you know, where you pair up with somebody, and let's say, Naomi, I said, you are going to be Rip Van Winkle. You were asleep for 200 years. You just woke up, and you're paired with Catherine. And Catherine, you need to explain to Naomi what Twitter is, or what Netflix is. And it's this fascinating thing when you try, or even what an airplane is actually, like when there's a list of things you could do, and you go, oh, how do I explain what's on an app on a phone before there's even a screen in their life? But then you use that to talk about the jargon that people feel when they don't, when they aren't understanding. They're the Rip Van Winkle, and you're doing this. I do magic professionally. I start a workshop I do on jargon by doing a magic trick. And then I instantly teach it, but I teach it using magician's jargon. And so I go through the whole thing, and I say, okay, and I do this, and everybody's excited because it's a good trick. And then they realize they don't know how to do it. And then I say, and if you can't pick up a deck of cards right now and do that trick because I just taught you in English, then you're non-compliant. And it's this gut moment. I mean, it's a really powerful moment that it's our fault when our patients aren't understanding us, not theirs. I'm a big fan of find what you're excited about, find a way to sneak it into teaching and improv game. We have a paper that I'll share afterward we just published that shares a lot of these techniques called it's in academic medicine about a month ago, and it was called pseudo improvised teaching. And it was about sort of what we talked about, how to be prepared with some scenario agnostic teaching things that can be dropped in when a trigger emerges that look improvised. And it came from I had a teacher when I was doing my sub-I who at some point asked a question about the Krebs cycle, a urea cycle defect, and he drew it on the board. This guy was about 83 years old. He's on it, drawing a Krebs cycle. And I remember thinking, it's the smartest person I've ever met. He just drew that from memory. At the end of my sub-I, he said, I found a way to get the urea cycle on the board the first few days of service every week for 40 years. I use it as a way to get people to think he knows what he's talking about, and he snuck this improvised teaching moment in, and it always stuck with me of like, what are some things you can have in your back pocket that can appear improvised, but actually can really be an engaging, powerful moment for people. So I'll share that paper too. Let's move to our last topic that was voted on. This is actually to be vulnerable, only the second time I've shared this. This was a framework we did as with our APDs, really thinking about how we in our program are trying to use vulnerability as one of our values, and like what that looks like to model it, what it looks like at the bedside, what it looks like as an administrator, what it looks like as a partner, you know, in home, you know, all these spaces. And so just to be on the same page, you know, the dictionary definition, being exposed to the possibility of being attacked or harmed, either physically or emotionally. I love that because we're thinking about like a turtle showing its underbelly, you know, like it's actually making itself vulnerable to wounds, you know, in that moment, whereas we tend to stay shell side up and out. Now, of course, you can't talk about vulnerability without talking about Brene Brown, you know, her framework on this uncertainty, risk, and emotional exposure. And so I think what was interesting is when we were talking about this, we always realized that I want to be vulnerable, but when do I enter the arena? When is the right time? And so I mentioned liking Venn diagrams. I'm just going to show you what we built as a Venn diagram here of when is the right time to be vulnerable. So the first thing is you have to have somebody to benefit. And that sounds obvious, but sometimes it's self-indulgent. You're really just being vulnerable for yourself to reflect on something, but it's not even going to benefit anybody by sharing that moment. So there is that first check. Is somebody besides me going to benefit from this moment of vulnerability? And then you have to ask the question, am I willing to take an emotional risk? And this is a question that does not apply equally. Privilege is majorly at play here, you know, and who gets to be vulnerable. Even my wife, and this wasn't about the privilege of our different genders in this story. It was the work environment that academic medicine allowed, and pediatrics gave us a space to be vulnerable. When I was sharing this with her, she goes, I could never acknowledge I don't know something to work in how it works in the business world. Like I would be eaten alive. So like it was not a psychologically safe space. And so that's the third piece, is having that what we call that psychosocial safety, to acknowledge the differing ability. That psychological safety implies that it's the same for everybody, recognizing that there are different moments that could require us to choose or not choose to be vulnerable based on our own lived experience and the way things could be weaponized against us. So this sweet spot, when we are able, someone benefits, willingness to take risk, and we have psychosocial safety, is a good moment for vulnerability. If I only have two, if I have someone to benefit and I have psychosocial safety, but I wasn't willing to take the risk, it's a missed opportunity. And that might manifest as shame manifesting as regret, you know, that I should have shared about the struggle in our marriage and this, you know, anything. It could be vulnerable. You know, when there's a moment that was there and we chose not to take the risk, we often find in that regret. If we don't have psychosocial safety, we run the risk of that vulnerability being weaponized and shame manifesting as embarrassment. Can you believe they cried? Can you believe they shared X, Y, or Z? And so that's kind of why we need to audit that scenario. And then if we don't have someone to benefit, that's that self-indulgence. It's just, you know, have you no shame. You're just kind of wasting everybody's time by telling your story in this. But this has been a helpful framework to say when vulnerability. Let's look at kind of what vulnerability could look like as a clinical educator, and then again with our patients and families. So I hinted at this. This is something that I do often. I label this vulnerability rounds, and I'll say tomorrow, and this is not a good thing to put somebody on the spot. You want to get people to think about this. Come prepared. I want us to all talk about something that we pretend to understand. For example, I recently realized I don't understand what urine osmolality is. You know, whatever the thing, I like to put one out there that I've struggled with so that people know. And actually, this is one my wife has done now at work in a business space, you know, with understanding data. You know, like I pretend to understand how we calculate percent change, for example. Safety confessions is another one, especially if an error has just happened, is just share the last time you made an error. You know, bring your personal story to an error you made. This is a true one for me of ordering Hib instead of Hep B for an infant, and the baby getting Hib and having to disclose that, and kind of the challenge around that. So, you know, rather, like if you're going to do this, create the space that shows that we're talking about this and role model the safety error or confession. I've been trying this one more, which is that we call this immediate redo. This is where something came out wrong and you want to try it right away. And it might be something along the lines of like, I walked out of the room and I say, you know, when I was chatting with the parents about the diagnosis, I immediately regretted framing it as bad news. Does anyone have ideas about what I could have done differently? But I think giving the safety for them to give you feedback, inviting it, showing that you're reflective, all of these are really powerful meta hidden curriculum type topics that can be powerful. Any ideas, but in that teaching environment where you've seen it used clinically, vulnerability used clinically, anyone have something to share?
Recently, we got a very nice talk from a physician at TCH that talked to us about explaining to learners from the very beginning of rounds to be called out whether on microaggressions if they notice them, just creating a really safe space for that, and how that's been working very well to invite people to say, that wasn't comfortable or that may have offended me in a much more common manner than it maybe was before that.
I love that. So actually setting the expectation, hey, let's be a space. We're likely going to say things we wish we'd said differently. Let's be a space where we can immediately give each other feedback on that. No, I think that's great. I have had the regret of not doing that fast enough recently. And again, you learn. We are all learning these constantly. So like powwow was a word I learned not to use recently. Like let's get together and have a powwow is a religious ceremony that we're trivializing. You wouldn't say let's get together and have a bat mitzvah. Like this is what the person that taught me said. You wouldn't use a religious ceremony in that context. And an attending came by when we were rounding and said, oh, can we powwow on this later? And I didn't seize the moment in that moment to share what I had learned recently, which is such a nice way to do it. Go, hey, you know what? I just got this feedback and I'm trying to stop using that word. Not, you shouldn't use that word anymore, Karen. Like that's stressful. But I didn't get it out yet. And then a learner who I learned was Indigenous said, I want to point something out that was said earlier. They beat me to it. And it was just this missed ally moment that I think is, so I love your idea of like creating that safety beforehand so that it's not weird if we call it out. Yeah. So let's look at some examples with our patients and families directly. Validation vulnerability is when we say things like, rather than I'm sorry, I'm late, is when we say I hate waiting for the doctor. I can't stand I kept you waiting. Like where we validate their anger. I mean, I'm talking to expert communicators here. That validation of anger is like the best tool to diffuse it. I would be furious. You're handling this better than I would is a really hard way for them to stay mad at you when they're angry about something. When we talk about compliance issues, I say, I might say, I miss my blood pressure usually 2 days, meds about 2 days a week. How are you doing? Give them the safety to say something in that space. My new one that's sort of pediatric inappropriate, but good for, we can say this because we're pediatricians. If we have to ask somebody about pooping in the hospital, which is very embarrassing when you're with, there's like 6 people rounding and we're asking when the last time they pooped. I say, okay, we're going to ask you a question, but we all need to answer it first. My answer is 9 a.m. And then I make everybody in the room answer the question. And then I have the kid answer the question. And it's kind of this funny, everybody poops moment. That's again, playful vulnerability. As pediatricians, raise your hand if you were the world's greatest parent before you had kids. I was excellent at this before we had kids. Very good at judging people in restaurants and airplanes. So I I think people are afraid that the pediatrician, how many times has somebody apologized to you that their kid uses a phone or like a screen? And I'm like, oh, isn't that cute that you think my kids don't use screens? So I think owning some of the things as a parent that you can create a safe space for them to share. The way we even do teach back, instead of saying, tell me what I just taught you, I'll say, we talked about a lot. It'll help me if I hear in your own words what we talked about, so I can clarify anywhere areas that I wasn't clear. So I make it my fault, if they, as opposed to their fault in that quizzing question. And I'll tell you, the only time I've ever had families that did not vaccinate change to being vaccinating families was when I shared that even though I knew the data, and I'm a firm believer in vaccine, all my kids were vaccinated, I was nervous when the needle went in because it was just talked about so much. I was anxious about it. I still did it. I'm glad I did, but I would be lying if I didn't told you I wasn't nervous about it. And this mom burst into tears and was like, nobody will ever say that. They'll just make me feel bad for having a question. So again, I think if we can be human and vulnerable as a validation tool, it's really powerful. And then I imagine this is already being done in your field. This is something I started in COVID, but it was just when people were when on the day of discharge, when we'd say the room, I'd say, okay, you know, they've been with us for a week. I'd love everybody to share something. This is in the room with the patient that they learned from Tommy, or that they're grateful for learning from Tommy, and just have everybody share a brief second, like as a popcorn thing. And this is one of those things where usually the learners have tears in their eyes, the families have tears in their eyes, the nurses, you know, it's just a nice way to bring gratitude into what we're doing. So I think, like I said, I've probably done this a dozen times and it's never been wrong. And then I'll just end with and again, I feel weird talking to palliative care doctors about this, but you know, the ability to show your emotion is not a bad thing. And I remember being taught, and actually I love your feedback on this, but I remember being, you know, you never let a patient see you cry, or in those moments, and going out of the PICU and crying in the bathroom. And I about 4 years ago, I was taking care of a family that that was there. They were there for end of life care. You know, she had a terminal genetic diagnosis. It's complex. They weren't telling the rest of her family that. So it was this. And about the third day, the family was Muslim. Mom wore a hijab, and I had never used touch. I did a great relationship with her, but I'd never put my hand on her shoulder or used touch. And the day that the daughter was dying, the siblings were going to come in, and I realized, kind of as they were talking about them, that, you know, at that point, there was a 14-month-old. All three kids were exactly the same age and gender breakdown as they were walking in. I had a daughter the exact same age as the daughter that was dying. And as I kind of realized that, my voice cracked. And the mom jumped from her chair. The dad walked over. They threw their arms around me and said, "Thank you for caring enough to cry." And, you know, this just really powerful moment that I was afraid to use touch. They used touch. I was afraid to show emotion. They validated my emotion. They weren't consoling me. They were grateful for that shared experience together. So I know, again, I'm preaching to the choir here about not being afraid to be vulnerable with our own emotions here. That can be very, very powerful for families. So with that, I will make sure that you have these slides and some of the articles, specifically the pseudo improv paper, the game-based learning, and the chalk talk paper. I'll send these slides to Naomi, but with that, I love thoughts, questions, and just chatting.
Thank you so much, Mike. I think you've inspired all of us to actually, I don't know if you saw the note in the chat earlier. We were talking about getting a group of us to kind of work on this collaboratively. This was when talking about chalk talks, but I think it also would hold true, like our different ideas about using more games in some of our teaching. And I think we could also use NIPSI as a way to share some of those ideas to really bring a lot more fun into our teaching. So thank you so much.
Right. Well, yeah, and I do that with our fellows. They do a chalk talk elective, and they have to generate 10, and then they come together and we give feedback on them. But now they've essentially left with 30 because of, you know, everybody sharing with each other. So that's a nice idea. You could do that with one. Everybody has to come up with one.
And I wonder if you breezed over something that piqued my interest a lot when you talked about psychosocial safety versus psychological safety. It's something that I've had conversations about recently, about that term, psychological safety. I wonder if we have a minute, if you wouldn't just share a little bit more about the difference between those two and how important that is.
Yeah, I think like a lot of that came from a conversation I had. So I do a lot of research on jargon and jargon oblivion, kind of highlighting what doctors think that they're saying one way, but families don't actually understand. And I was giving this talk. I've done this grand rounds a ton, and somebody afterwards said, you know, as an IMG, I don't feel like I have the privilege to speak plainly. I feel like I need to use jargon to show my credibility, and because I'm not given the same. And so it was this really powerful moment of like, wow, the privilege to, like, I'm learning all of this, right, as we all are. But the privilege to speak plainly is another privilege, you know, because of biases that are being carried into the room the second the door opens. So when we were then doing this work on vulnerability and we put that, one of the chief residents was like, I've always, that term has always bothered me. And we just kind of started to think about what is another frame for that and what would be a phrasing, a portmanteau that could highlight that this is not uniformly applied. So it was a slide change 10 minutes before we gave the talk. So I don't want to make it seem like it was a deeply thought out framework and researched theory. It was, yeah, that's a brilliant way to think of this. Let's change it. Well, I'm glad you guys have these groups. These peer-based groups are huge. You know, having an academic family, especially when you're often can be a lone wolf at your own institution, I think are so important. You know, and that's again how I knew Tanya, through kind of an academic family of global health. And so just I'm grateful to see that you guys have done this. Thanks for having me. I'll stick around if anybody has questions, but I will also give the gift of time to those that want to hop off.
Thank you so much, Mike.
Naomi, did you want us to each send you like one of our ideas for those?
Sure. I mean, if you want to take like some time now, send it to me. Otherwise, I'll include it. We send like a little after we send kind of like a little Pearls summary to the whole listserv, so I can
Okay.
ask if there are others who want to participate. But yeah, that's great to kind of capitalize on all of our excitement at this moment in time, to just send it to me. And then I wonder if we should just share it on the NIPSI website, or we'll figure out the best way to share it.
I loved this. Thank you, Michael. It's great.
Everybody
Yeah,
have a good
thank
one.
you so much, Mike.
Bye.
You.